I know you're all having lunch. There's a little queue of people also waiting for their lunch, and the panel have got their lunch. But my suggestion would be that if anybody's got some questions that they'd like to ask the panel, just we'll get things rolling. So, if anybody got any burning issues that they'd like to ask the panel?
The new drugs. You have two that are licensed in this country, rivaroxaban and dabigatran. And it's going to be very interesting to see what happens with these drugs because there is no antidote for them. There's no way to know really if they've been given or not. They're renally excreted in older people. That may be a problem. In patients with certain other medications, particularly rivaroxaban, that could be a problem. In surgical patients, the surgical site bleeding wasn't included in the trials, so we know that there's a little more bleeding with rivaroxaban. And despite, and now there have been recently some excellent data in atrial fibrillation with two very good trials, and also DVT extended prophylaxis trial. Having said all of this, I think that there'll still be, this is not going to replace Coumadin. There are a lot of people that are doing well on Coumadin, will continue to stay on Coumadin. I think that, if anything, it will revolutionize the out-of-hospital prophylaxis because a lot of the arguments that I make for continuing patients after hospitalization, certainly in the United States, that's very difficult because of the cost of the injections. So that I think it will be able to play a major role. I'm not sure about Plavix. I'm not sure to what extent that's really going to fit into the picture for venous thrombosis. I think for arterial indications it has a big future, but not specifically for venous thrombosis.
Can I just take that extension slightly further to Tony? In those patients who've had an iliac vein stent put in, and they're initially on anticoagulation with vitamin K antagonist, do you think, like in the arterial circulation, there will be some evidence to use Plavix if you are actually going to take those patients off their warfarin or Coumadin?
Well, I will say that we put all of our patients on aspirin and Plavix, as well as warfarin after acute stenting for the May Thurner at the time of iliofemoral DVT thrombolysis. We will keep them on combined platelet inhibition for about 6 to 8 weeks, at which time, and we don't have any human data to support this, although there are animal data suggesting that the stent is re-endothelialized by about 8 to 10 weeks, certainly 12 weeks. So that's the reason for the combined platelet inhibition. And then most of our patients with extensive venous thrombosis we think ought to be treated for a minimum of a year, if not more. So we will give prolonged anticoagulation in these patients.
Do you have any other questions? No? Any other questions for the panel?
I just I would raise well, Dr. O'Sullivan's not here yet, but he mentioned that one contraindication, catheter-directed thrombolysis, was the pregnant patient, and I would disagree with that quite enthusiastically. Pregnant women are obviously young, and they have the majority of their life ahead of them. And if there's any group of patients that are likely to benefit from having extensive venous thrombosis, extensive iliofemoral DVT treated, it's the pregnant woman. So we have managed those patients with catheter-based techniques. The majority of them are in their 3rd trimester, so radiation is not a major concern because the fetus is already